surgeon wellness can have many different components. So this is a pretty free-form conversation and discussion. So we're not on any one specific wellness topic. And so I look forward to getting as many perspectives as I can on the conversation. And that's where I think the community is particularly important. You know, to me and why I'm doing this, what motivates me to organize these is really about all of you and trying to help all my colleagues that are out there doing their thing. And I'll just say I care about you. And so I want you to pay attention to yourselves a little bit tonight. It's okay if you're worried about others too, but also pay some attention to yourself, please. There's other key points. I'll just leave this slide up a little bit. I want to welcome, actually I have so many friends and colleagues on here, but I know that Phil has joined us. I've been inviting Phil for weeks and weeks and weeks, and he says, keep inviting me, keep inviting me. It's just not working out. How are you doing, Phil?
Doing great. Thanks for your resiliency in not forgetting your old friends.
So not everyone on the call knows you. I know you should be famous for your fantastic book. But can you just share a little brief self-bio of who you are and what you're doing these days?
Sure. My name is Phil. I'm a trauma surgeon from Europe originally. Been in Denver now for more than 15 years. And for the past 3 years, as a chief medical officer, I just moved to a new hospital in Aurora, Colorado. And we turned into the #1 cohorting COVID medical center in the state of Colorado, coincidentally. So my onboarding was pretty streamlined. And we've had more than 100 COVID positive patients at any given point in time in our cohorting units. So it's been pretty busy in the past couple of months. And I've learned a lot about resilience and physician wellness.
Excellent. And we'll definitely want to include you in the conversation. So, and then I understand anyone that may need to run off, just speak up, or if you have the ability to go in the chat and warn Paul might warn me if any of you guys are on a time schedule, and just want to make sure that you share something important with our community. I'll be glad to fit you in. How's your day, Phil? You good for a little bit? If I can introduce a couple other people.
I'm going to stick around. Let
Okay.
me know if you don't hear me while I'm outside. It's a little windy here, but I can change my location otherwise.
Awesome. Thank you. And then, hey, Ben, how you doing?
I'm doing well. I hope you guys are too, and trying to enjoy a beautiful day with some family.
Excellent. So it's always that tough balance when you have a topic as exciting as wellness to talk about, and yet you're also trying to appreciate the real life wellness of being with your family. So I definitely appreciate your being with us today. Can you do the same thing as Phil did and just give a little brief introduction of who you are and you know, where you're at and what you're doing?
Sure. My name is Ben Zerlip. I'm an orthopedic surgeon in Austin, Texas, specializing in shoulder and elbow. And I'm in a private practice model, so we've been kind of financially, I would say, limited or concerned with the COVID crisis and non-elective surgeries, but we've navigated well, been able to navigate the financial obstacles with these small business loans. And then we're starting elective surgery in Texas this week.
Excellent. So, and I think, going an hour goes by super fast, but I think keeping the conversation moving forward, I think if we have a little bit of time, I think it'd be really good to share how people are addressing the resumption of elective surgery from several different perspectives. That would be awesome. But I don't want to be the only person that picks the topic, but that's something that I think that from what I'm hearing from a lot of people that they're asking about, and how to in a way, do it well, but also to do it with an attention to surgeon and patient wellness. Is that Anne-Marie? Could we, well, let me, Kathy, why don't you say hi? I can see you well.
Hi, I'm Kathy Hughes. I'm a general surgeon coming to you from Falmouth, Massachusetts on Cape Cod. I've been doing sort of a locums per diem acute care model. So got sidelined more or less fairly early on in the process. But I've been sort of cheerleading from the sidelines, following the medicine and the physicians, and doing some advocacy and some writing and sort of in the support side of things.
Excellent. And I see, is that Susan?
Yes. Hi. Hi, Jeff.
How you doing? Thanks for joining us.
Yes.
And I hope you, I know you're excited to be here. Why don't you share a little bit about who you are and what you're doing?
Yeah, so I actually am a retired emergency medicine physician. I did my training actually in Milwaukee, Wisconsin. So I worked for about 25 years in Milwaukee. I did do 2 years of general surgery residency before switching to ER. So I feel a little bit of kinship to the surgeon group. And after retiring from clinical medicine, I actually became certified as a professional coach. And so I'm really excited about pursuing coaching specifically for healthcare professionals with regards to burnout and job satisfaction, and then also the whole concept of peer support. And so these weekly webinars have been super interesting to me from that standpoint, and just trying to get involved as much as possible to help people kind of navigate through this time, because it's obviously so stressful and anxiety provoking.
Excellent. And obviously I'm very biased, and I'm biased in favor of having anyone be part of this that's interested in peer support. So thank you for joining us. And I think there's so many folks that I can't keep all your faces on the screen and multitask like I'm doing, but I see Ron Navarro. Can you, how you doing?
Hey, Jeff, thanks for having me. Doing okay, just managing through.
Excellent. And Ron, how about introducing yourself to those
Sure.
that are on the call currently?
Sure. I work in the Kaiser Permanente system, orthopedic surgeon, 23 years in the system. Now oversee, with the help of others collaboratively, the 13 medical centers in Southern California orthopedically, and the over 250 orthopedic surgeons. So we've been all working, but where we can, and we certainly began limited work many weeks ago, and we're planning on resumption of something akin to a normal in the second to third week of May, but that's still being bantied about. And orthopedically, I was just sending an email off. I have the largest backlog of all the surgical groups in my general practice that treats 4.7 million patients. So the thousands of patients that are backed up or backlogged, I have to have oversight over that. So we want to do the ramp up safely, but we also have to get through it too, because patients need their surgeries at some point.
Ron, that's excellent. And I do have probably one or two other introduced, but I do want to not spend all the time on introductions. And I thought I'd go ahead and ask you if you wouldn't mind adding to a little bit of that experience. I mean, I really see you as representing so many different angles. The California angle, the California Orthopedic Association, a Kaiser, pretty impressively big size system, and just an all-around good guy surgeon. So why don't you take it from there?
Yeah, that's nice of you to say, Jeff. I was especially interested in just in your ask of me to come on, and I really admired your work. And we had you come out and talk to us recently, a big group of orthopedic surgeons in February before the world shut down, and so we really appreciated what you taught us. But specific to this, everybody on the phone, there have been different groups who've been called to the front lines, if you will, and yet other groups who are very commonly ready to handle the big problems, surgeons per se, and others have been kind of relegated to the back. And I got to tell you that at times there's been a sense that surgeons have been shamed because they are looked at as if to be told you're not doing what the critical care physician is doing, and things like that. So, and Jeff will tell you, he knows me a little bit more. I'm not the guy who talks about being bullied or anything like that. But I really felt like at times we were being bullied or being cast aside or castigated through no fault of our own. So in my system, I've been specifically calling out to just protect surgeons in the wording that people use, insofar as making them feel ashamed for not having to do all the work now, because they're certainly going to do a lot of work later, and I don't think that the critical care doctors will be helping them with their surgeries late at night at that point. And so it was that was I think that's where you wanted me to go, Jeff. And so I don't know if that prompts some conversation. I'll stop there.
Well, excellent. We have tons of other, well, not tons. We have several other panelists and several other guests. So anyone else on our panel that want to respond to that concept of shaming and how Ron's shared it so far? Kathy?
Yeah, well, being sort of out there in the social media world and sort of tracking what's the conversations that have been going around, I was just going to observe that surgeons are falling into sort of two camps. Any of the surgeons that have formal critical care training are being pulled into the ICU, often, the medical ICU setting. A local colleague of mine who's a pediatric trauma surgeon has been doing adult critical care. So there's that whole cohort of surgeons who are a little bit out of their usual area of expertise. And then there's this much larger cohort of surgeons, either because of the nature of their practice, orthopedic surgeons, vascular surgeons, or that are being furloughed or dramatically reduced. And it's actually going to start blogging about this. I mean, surgeons are used to being the pointy end of the spear. The kind of big deal, whether you're trauma or whatever, that's the space that we've been trained up to occupy. So I think it's been very difficult for the surgeons who aren't in the trenches. I'm not sure if it's as much guilt as shame. I think there's a lot of guilt that we aren't there in the thick of it with some of our other colleagues, which is where we are used to occupying.
Excellent. Others can certainly chime in. I thought I would go ahead, and since we're talking about guilt and shame and a few other terms that I think there's some expertise in clinical psychology. I don't know if we have any clinical psychologists available on our panel.
Hi, I think you may be referring to me. So I'm Anne-Marie Warren. I'm a clinical psychologist, and this person lurking in the corner is Alan Jones. I think several of you know him more than you know me. my husband, but I'm a clinical psychologist and researcher, and Alan and I are both at Baylor Scott and White Health, and we're at Baylor University Medical Center, which is probably where we're having most of the cases. I find this discussion so interesting because I think that people thought from a wellness perspective for our physicians and other healthcare workers that the crisis would really be at the beginning of the crisis. I think people are not kind of hitting that psychological response yet. I think that's going to be more down the road. I think we're going to have a lot of downstream effect of this. We started a peer support crisis line for all of our healthcare workers. And interestingly, it has not been very well used. Again, I think it's going to be down the road when the emotional piece will hit people maybe a little more. And that may be more for Texas, but that's what we're seeing right now. But I think there's going to be issues that'll be coming up for quite a while.
Excellent. And I know I might be able to turn things over to you to share your screen, but I thought I would try to find what you had sent me and post that. Let me see. Let me try this. I'll be doing that. I know you're very much into the research of these things. So let me pull that up and maybe you can give a little bit of a share on the research, because obviously we're learning in this process, whether we anticipate it coming early or late. Actually knowing what the impact was is going to require some research, I assume. And so let me see if I can share my screen again and see if this helps us at all. So you guys seeing the psychological impact to COVID-19?
Yes. Mm-hmm.
Yes. And thank you so much. I'll very briefly talk about this. So I think it kind of gets back to the point where, I think there's a lot of assumptions about what people will experience emotionally, not just healthcare workers, but the community at large. But I think until we know what happens and how people react, we can't assume everyone will respond the same way. And that's the danger, right? With a lot of the stuff that's coming out, that everyone's going to have PTSD or everyone's going to be depressed and anxious. We don't necessarily know that. And so we felt strongly it was important to do research on not just the potential negative impact of COVID-19, but maybe more importantly, how people are resilient, how they're coping, what strategies are working for people, what's helping with lifestyle changes. So we've started this large study. We're going to follow people for 2 years. And we're really looking for anyone that wants to participate. Shameless plug, Jeff, thank you so much for letting me talk about the study tonight. But most importantly, I feel strongly we don't know. We have a little bit of knowledge from folks, healthcare workers in China, there's been some articles published in the Lancet about how they're responding to COVID-19. And of course, they're experiencing depression, anxiety. But we really want to understand how this is impacting people. But most importantly, if we understand what's working for people, then we can develop interventions to reduce the negative effect that it's having.
Anne-Marie, thank you so much. I'm going to leave this up for just a little bit to just remind folks of their opportunity to participate. And, since the audience here is a big mix of academic and private and even private with research interest, folks might have some follow-up and interesting questions for you privately, but certainly they can do it on this format as well. Either, not to bounce around too much, either anything that Ron shared or anything that Anne-Marie shared that others want to ask about or comment on.
Hey, Jeff, this is Sue. I would just like to actually comment on a couple of things. First of all, the whole concept of guilt. So as I mentioned to everyone, I retired from emergency medicine just this past year in June. And so this whole situation has made me feel very guilty that I'm not working clinically. And actually my husband also practices emergency medicine and he's still practicing as we speak. And so I've had a lot of mixed emotions about this. and thinking, how can I help? And so that has, I think, motivated me then also to try to get the word out about peer support and help people in any way I can. The thing I've also noticed, and I guess my experience is more anecdotal, is that people, even though you're offering peer support, and I'm offering this for people gratis, and I've reached out to multiple groups, through social media, no one seems to be taking advantage of this. And I kind of feel like maybe people are just so shell-shocked right now, and I just think about like working in the emergency department itself. I mean, people I think are just going and doing their shift and then just going home, and they don't even want to think about it. So I'm hoping that people will eventually reach out for some support, because clearly comments I see on multiple different groups that I'm involved with, people definitely are stressed and anxious, but they just don't seem to be wanting to reach out right now. So I'm hoping that will change.
Well, go ahead.
The other thing I wanted to just mention, because one thing that Anne-Marie had sort of just kind of alluded to, was something positive coming out of this whole COVID-19 experience. And I do think that there has been a lot of people that feel actually that they're now getting more in touch with their families. They are being kind of forced to slow down a bit, and it's helping people to kind of reassess. So I think there are going to be definitely some positive interactions for people personally that come out of this whole experience.
For sure. And I would just highlight that keep reaching out. From your standpoint, I know that you're not necessarily feeling that people are taking you up on the offer, but I think the continued offer is likely to be fruitful over time, in my humble opinion, but I will certainly defer to others like Anne-Marie and others to comment as well.
Jeff, I had a question.
Yeah.
For Anne-Marie and for Susan too. One of the things that one of our critical care providers brought up was that at the start of just like Anne-Marie alluded to a little bit, at the start of the crisis, everybody has a lot of energy and focus on investigation and learning and stuff. But it's when it's towards the end or later on where really all that expertise and energy is needed, and many people have already lost that. And so I think it's true of our emotional resilience too, is that at the start you're ready for battle and ready to do whatever, and then when it comes down to the mundane things of trying to figure out who to screen and all that stuff, you kind of lose your focus and lose your discipline at the time when you really need it the most. Your thoughts on that?
Anne-Marie, you want to take it, or Susan?
I would say, I think Susan was going that direction, but I think that's what we're seeing, is that people are just, I liked what she used, the word shell shock. People are just doing what they have to do. And I think a lot of this stuff is going to come later. But again, I would defer to Susan, because I think she had some really good points on this.
Well, the other thing that comes to my mind is the whole concept that this is truly a marathon and it's not a sprint. And I think that we're obviously, now that we're learning more and more about how, anticipating maybe that there's going to be a second wave of cases, in the fall. And I mean, I think realizing that this isn't just something that's a few months and it's gone, it's done with. I mean, I think we all have to sort of have that mindset that, yeah, we really need to pace ourselves. And I think that's going to be something that's going to be really, really important for, all the healthcare providers that, moving forward, is just, kind of that whole concept.
So one of my perspectives is that's a huge part of us trying to grow a community. Because I think that when you are part of a community, just like you're potentially part of a call panel, that if you're not on call, you don't have to be in and doing it. If you're part of a community that's providing peer support, you too can take a break. You too can have the opportunity to recharge and not just sprint out and try and do everything, passing the baton, or the program, for example, with the California Medical Association and Physician Wellbeing, they're highlighting that even the people offering peer support need the community of peer support to tap into as well. And I think it's, to me, it's that hope that those glimpses of normal emotions like shame or guilt or anxiety or sadness, depression, whatever the emotion, that you still have the ability to acknowledge that, but not get in a cycle of perseverating on it or going down the rabbit hole, and being able to step back and recover. Others on the panel, I don't want to focus on the negative, but I like the positive strategies and technique of what Ron's doing with addressing efforts to shame. So, and many times it's unintentional, right? Just the poorly chosen word, or wow, just the accidental word of social distancing, and how potentially that's such a difficult term when it really should just be physical distancing or precautions and care, rather than distancing from others. Like, that's not what we're trying to do. So any other comments or strategies for addressing the concept of shaming, whether it's intentional or not? Anyone? Phil, unmute, or do we have to unmute you because of your background windy noise?
Me.
All right, you're back.
Hey, Jeff. This is such a great group. And what I would like to add, I've been a trauma surgeon all my life, taking call, as you know, like a busy level 1 trauma centers. And for the past 3 years, I've been a chief medical officer. And many of my colleagues asked, why do you do that? And you're now an administrator, you went over to the dark side. And I think I've worked more hours in the week now, contrary to many of my colleagues, than ever before. It's almost like you're healing a community. And what I do every day diligently, I call those who are left at home, because I know they suffer as much, and they feel guilty for not being able to fight the fight and the battle with us. And I emphasize how important it is, A, for them to stay home, B, they are not forgotten, and C, many of them, they come in and help us, like we just heard earlier, trauma surgeons coming in to do lines and to do all the work in the ICU, medical ICU, that they would have never been asked to do previously. And the level of collegiality and cohesiveness, and I'm 54 years old, I've never seen in my entire life, my entire career. And that's part of what promotes my resilience in all of this, is we stick together, almost like in a battle or in a war. We know we're going to win the war, and we don't know how long it's going to take. And I really want to thank everyone on this panel for all the work you do, whether you are actively working in the hospital or actively staying at home, supporting everyone who is at the hospital. And I've never seen so much sense of gratitude from the community for the work we do. I've not seen a single surgeon get shamed from what I heard earlier on this call. This is novel to me. We get a lot of letters from first graders who thank us for everything we do, and that includes the surgeons. And like we heard earlier, they're going to be grateful when the patients come back to have the desperately needed what they call elective surgery, but it's truly essential and a really urgent surgery. Because if you look at the numbers, the 65,000 dead in the United States from COVID-19 is horrible, but it's about tenfold that from heart and cardiovascular disease every year, and 500,000 from cancer. So all the neglected care, the screening that gets missed. And I just talked to my cardiothoracic surgeon on my drive home before I took this call, and he said, I did an emergent CABG of a patient who stayed home and had a heart attack, and then only came to the hospital with a heart attack. And we see patients come in with strokes or stay at home with strokes. So kudos to all of you, those who are at the hospital and those who stay home, and don't ever be shamed by anyone. Otherwise, give them my cell phone number and I'll talk to them from the perspective of a COVID doctor.
Sounds like between you and Ron and others, we have some anti-shaming advocates. That's awesome. Other folks to add to what Phil's saying. Phil,
I mean,
sorry, go ahead.
It's Ron. I think Phil hits on a really important topic, just the general appreciation for the work done for all healthcare workers and all people who are trying to solve for this or help in the fight. Has been really heartwarming, and so that's something that kind of can gird people through the long haul. I think it's amazing and fortunate. There's other things. I've seen so many people be so much more productive. You talk about academics, Jeff, and there's a few of us who have seen this as an opportunity to kind of understand what this means for our patient populations and COVID. And it can make for a hyper-productive period. And so I don't know if that's some sort of reaction formation and you're just trying to deal with everything in a way that makes sense to you. But I think there's going to be a lot of interesting work come out of this that will help us to both with respect to COVID and then also to work, as Phil was pointing out, and how we work better together and how we've come together and how we can learn from that and bring that to other ways that we have to monitor and deal with all of the issues of healthcare administration as physicians.
Excellent comments. So there's a question from a surgical colleague of ours who happens to be a vascular surgeon, but it's an excellent question for anyone and potentially everyone on the panel to answer. So if you knew, and I'll start with Ron and Phil, because you guys potentially, and I may be wrong, but you potentially have the leadership and system-based answers to this. I'd be curious, if you knew your surgical volume, and this is speaking a little bit to the individual surgeon, if you knew your surgical volume this time next year was only going to be 50% of usual, what would you do?
Phil, you go first.
Well, to be honest with you, first of all, the surgical volumes will ramp up. We just started last week. Everyone calls it elective surgery. We all know it's not. What I call elective surgery is discretional surgery, a bunion or a liposuction. Everything else is really urgent, including obviously cancer surgery, cardiovascular surgery, but even bariatric surgery is important and timely because patients have adverse outcomes if they don't have surgery within 3 months or so. So I have no concern that all of your surgeries will ramp up again once people lose that anxiety of going to the hospital. On Saturday morning, I did a virtual town hall with legislators in our community. And I emphasized the analogy of the fear of the common people of flying. And you're scared of boarding a plane to fly from A to B, but you're not scared of sitting in the car and driving to the airport. The analogy is the fear of getting into a hospital. Hospitals have figured it out how to be safe. There's universal masking policies, hand hygiene, terminal cleaning, temperature screening. You're nowhere safer than in the hospital, as much as you're safe being in an airplane. But the big risk is you're going out there in the community. I see all these folks going back out into the grocery stores, hardware stores with no masks and no consideration for all the precautions that are recommended. And that's truly where the whole viral shedding and exposure occurs. not in the hospital. I've been in this now 2.5 months. I still feel pretty healthy. I just ran a half marathon yesterday and a marathon last week. And I'm not saying that to brag. I'm saying it because that's part of the resiliency. We have to do things that keep us healthy, and we have to keep some common sense in how we address this. So in my video to our own patients explaining why they need to seek care with their primary care physician, I emphasize that the risk of getting sick or dying from neglected care or delayed care is much, much higher than the risk of dying from that virus. And that with the simple, appropriate precautions that are shown anywhere through the CDC, on television and the media, simple masking, hand hygiene, social distancing will keep you safe. And again, I think that's a strong and compelling argument that as surgeons, we're going to do fine. I just heard that 10,000 of pilots will be laid off probably forever because the airline industry will never recover from what it was before. That's horrendous. If you think about it, just 3 months ago, it would have been the coolest thing to be a pilot, and now they're all being laid off. I don't think surgeons or physicians, for that matter, have to worry about that for 1 second. We will be needed more than ever before.
Ron, you want to follow up?
I appreciate Phil's comments. I think to John, who made the question, I think I'm going to hedge my bet a little bit and say it depends upon what kind of system you're in. If you're in a fee-for-service system, it may be more difficult to have a 50% reduction in care in cases. If you're in a system that is where you're a hired physician for a hospital system, or like in my system where you belong to a partnership that has a symbiotic relationship with an insurance company, then maybe you can weather the storm. So I think he was probably describing it just to kind of argue the point or beg the point in the system that's a fee-for-service system. And so in those situations, it's probably difficult. I do have to agree with Phil that the cases won't go away. But in the here and now, we're hearing in California and several other states, there's several groups that are having difficulty that rely upon primarily a more elective surgery. I completely agree with Phil. If you have pain, that's not elective. It's not like getting, a cosmetic surgery, if you will. And so in those cases, I think they're going to ramp up again. Are some of our younger surgeons' lives disrupted because they were the last in to a partnership and are probably the first out in the next couple of months? Yes, but there will be cases, as Phil says. So I'm kind of answering the question both ways. If you're in fee-for-service, it might be tough for you now, but there's going to be procedures you'll have to do because people's arthritis won't go away. They're still going to have arthritis, and they're still going to have to be solved for it. Certainly where Phil's in trauma, there's always still going to be trauma.
Other panelists' comments?
I don't mind commenting. I'm not a panelist, but I'll comment. But I think it's a really interesting observation that both our economy is so dependent on, the retail and restaurant and things like that. And I think it's also telling that most hospital systems are so inherently dependent on orthopedic and other elective or semi-elective surgeries. We stopped doing elective surgery. We're still taking care of sick people, but our hospital revenues, our system revenues down 48%. It's unbelievable amounts of money. So if I knew things were going to be at 50% next year, I think I'd probably make some moves in my organization to not make us so dependent on elective surgery.
Yeah. So speaking a twist, I'll introduce Dan to the conversation. He's been with us many times before, and I know Dan's. When you weren't here, I had a few folks give a little brief bio themselves, but I'll kind of have you do that as well, Dan. But lead into, I know that you're a big health disparities advocate. and I noticed on social media that you've announced a new way, and you've been doing this before, but you announced it as a drive recently to find ways to address health disparities at a younger level. And I would invite you to share that in addition to your bio.
Well, I think the challenge that they run into with this disease right now, there were a few articles that came out where if you look in Chicago and in New York, they had the Javits Center in New York, which was a massive Army Corps of Engineers build out. And what they ended up doing, like in Chicago at the McCormick Center, they were poaching talent from the safety net hospitals. They were paying hourly rates that were 3 times what these nurses were getting locally. So, you know, I think what this showed is that there is an incredible lack of headroom with regard to staffing and skill level in these safety net hospitals. We've done remarkably well in Illinois, but if you've read the numbers with regard to disparity, I think the African-American, the elderly and comorbid populations have been, you know, 70% of the deaths here in Chicago. And the hospitals that, you know, that we have been treating them at have been understaffed, they've been under-resourced. And I think, I don't know that you're gonna find the talent that is out there because, you know, money always talks, and I'm a free market guy, and I believe that if you can do better, you should. But once the talent leaves, there's no second and third layer like we have at a lot of the other centers. They may have a nursing school, they may have other avenues to bring people in. You know, we lost like half of the nursing staffs at 3 of the major safety net hospitals. So, you know, we're just trying to figure out ways to go within the system to develop talent from the high schools up where there's really not a pipeline to get these folks involved from a ground level and to build a relationship with them with the desire that they will serve their communities when they finish becoming MAs, nurses, or doctors. And I think, you know, we work a lot with students on the medical student level, residents, but, you know, the high schools have been really difficult because, you know, for a variety of reasons, transportation may be difficult, but I do mentor a lot of med students. I want to try to take that model to many of the inner city schools where they you know, they cut everything. They cut arts, they cut sports, they cut gym class. And a lot of these young men, I talked to a lot of my former basketball friends that are mentoring young Black men. And I think the biggest problem is that there's really no one in the system to get them attracted to medicine. They're at risk. And at the end, you know, when these disasters happen, we don't really have a talent pool to draw from. I mean, who really, other than my crazy self, wants to go into underserved areas and treat these patients? And but many of them, when they find out, we do have many medical students that are coming back now. And I think we have to start at this pandemic really exposed that, you know, the disparity isn't just in the patient care, it's in the resources, it's in the talent pool. And this just really exposed a lot of weakness across the board. And it's just the way we're trying to address it. It'll be a project, but it'll be a fun project. I do enjoy working with high school kids.
Well, congratulations on all the things you've done up to this point, and congratulations on adding that at this time. As Phil would highlight, takes a very resilient person like you to keep trying to make something positive out of the adversity that many are experiencing.
I think it requires being 7 feet tall, slightly not right mentally, and believing that it could get done. So if you guys want some limb lengthening, I'd love to have you on board.
I could use another foot probably, but I gave up on that a long time ago.
Help.
Excellent. So, you know, just I think I might have lost Ben from earlier. I don't know if Ben's back on with us. Hopefully Ben will join us again. I want to open this up to other people, but I think what I'd like to spend our remaining time on is just highlighting silver linings and things that, again, the positives that people are hoping to get out of this experience. And maybe I could start with you, Susan.
Yeah, so yeah, just I was kind of hoping I could get to talk about my positives because I've actually felt that this for me personally has been a good experience. As I said, my husband is also an emergency medicine physician. So he actually has left. I'm in Southern California right now, and this is where we are in the winter. And he actually has been commuting back and forth to Milwaukee. And now he is just, about 3 weeks ago, he went to Milwaukee and he's just staying. He's actually helping to set up the ACF, the field hospital, if you will, in Milwaukee in anticipation of cases, a surge there. So I am here with our 2 adult children, and I just have had, you know, they would not be here if it wasn't for this pandemic. My daughter's actually here living with us, working from home, and our son is a sports broadcaster who now has no work because there's no sports. So he actually came here and is living with us, you know, until his work starts up again. And so for me, this has been a really positive experience because I've had all this time with my kids. We've just, you know, had a really close family connection. And I think a lot of people are going to have that kind of experience, that they're just, even if they're still working, I mean, if they're going to the hospital, they're working, but then they're coming home and everyone's at home because no one's going to school, no one's away. So I think in that regard, this is really tightening up a lot of family units. And as I said earlier, I really think this whole experience is going to give a lot of people an opportunity to kind of step back and sort of reassess and reevaluate their lives and what they've considered important. And one other thing I just wanted to mention, which I realize kind of sounds sort of altruistic and maybe, you know, it's a little bit touchy-feely, but I kind of feel like this whole thing, as adverse as it is for physicians specifically, I kind of feel like it gets us all back then to why did we go into medicine in the first place? And I mean, if you think back to when you were in college and thinking about going to medical school, you know, what actually motivated all of us to go to medical school in the first place and become physicians. And so as corny as it sounds, I do still think that we all really want to help people. And I think we're just now having to navigate a different way that we can do that. And I think we're going to get there. We will definitely get there, but this is going to just kind of be the impetus for finding a new way that we practice.
Thank you so much. Very well said. Ron.
Just thinking about what you're saying and what was just said, there have been some great things. You know, we see that our coastline looks cleaner than ever before. The skyline is cleaner. The red tides in Southern California have led to some really cool bioluminescence at night, and I get to go down there with my kids. And I've lived in California my whole life, never took the time to go down at night. I always just thought, you can't surf during the red tide. It's nasty. But now you were appreciating stuff that we didn't used to before with our loved ones. And so that's a piece of kind of the way forward, maybe to retain some of that and not forget about that and get back in the rat race as much when we go out the back end of this. And so that's top of mind for me right now.
Thanks so much, Ron. Kathy, silver linings, hopes out of all this.
Well, I think, you know, I live by myself, so this hasn't been that much of a stretch for me to adjust. But one of the things I've gotten to think about and talk about with some of my colleagues is that we've been right about a lot of things for a long time as a profession, about how we can't let the bean counters run things. We can't run things where we're like nothing left on the shelf and no options. And we're being vindicated in the most horrible way possible, but we are being vindicated. And I think we have this opportunity as a profession to navigate this. We have a lot of goodwill from the public, perhaps except for the people that are protesting and trying to demonize us, but I think in general, we've got the attention of our government leaders, we've got the attention of the patients and the general public who are seeing that, you know, healthcare workers and physicians were not, you know, all of the things that were burning us out, all of the things that we've been talking about for so long, we're being vindicated about. And I think there's a real opportunity for us to get our voices back, for us to be empowered again, for us to have more agency in and have the systems serve the physician-patient relationship again. Because really that's the center of healthcare, is that space between the physician and the patient. And I think this is our chance to reset and make sure that the systems are serving that instead of us serving the system. So sort of a 350,000 foot view, but.
No, it's excellent. I really appreciate your perspective and sharing that with everyone. I'm going to ask Phil to chime in. And Phil, you know, silver linings, hopes out of this. Now, I've known you a super long time, Phil, so this is really hard for you because you're such a positive person. You'll have too many things to say. I'm hoping that you could give us a couple, and then maybe what would be really helpful is how can we make your spirit contagious? That optimism being contagious would be a much friendlier virus than COVID-19.
Well, thanks, Jeff. I don't know if you can hear me because Paul keeps muting me because of the wind. Well, I have good news for Paul. I traded the wind for some dog barking in the background. But I believe that what's happening right now with COVID-19 was a long time coming, because nature has its own feedback regulatory mechanisms. And we've expanded too far with humankind. If you think when I was a kid, the human population was about 3 billion, and now we're closer to 7 billion. And with the whole technological revolution, I didn't even have a cell phone until I was 35 years old. And now our society has become so technological that we lost the human touch. Kids don't even know how to talk to each other anymore except through Skype or texting. So what I'm hoping, well, first of all, I'll say something negative. I believe that the COVID pandemic is analogous to the atomic bomb, because when the atomic bomb was invented, you can never make it go away again. Once a virus figures out the genome such that it's so contagious, because let's be very clear, the only thing that's scary about COVID-19 compared to Ebola, SARS, MERS, flu, is the level of contagiousness. And yes, there are many people suffering. There are horrible deaths, even in my own hospital. The youngest patient who died was 21 years old. And I followed his suffering, and I'm still in touch every day with his family. So you cannot make that up with any statistics. But I hope that when this is all over, and it's not going to go away, so our society will be renormalized. I hope we will gain some human touch back, away from technology, understanding what it means to hug someone, to high five someone, to have a conversation, to play a board game and read a book, as opposed to the fast-paced technological path we were pursuing. So that's my silver lining. I know we're going to be better as a humankind.
And interestingly, I don't know that Kathy or you have known each other or met each other before, but in a way your message is similar, or it has some crossover or a share of increased human touch. The experience that many physicians were looking for when they went in listen. Dan, any added comments, silver linings, hopes that you have out of all this?
I like what Kathy said. I think it's really important to understand the value of what we do. I think everybody who has tried to subspecialize and not remain diversified is sitting home, where I've been working straight through this. 1 week when there's a pandemic, I'm a trauma and an amputation doctor. And then when this calms down, I go back to doing spines and joints. I think the beauty is the tragedy that it had to get so bad for people to appreciate who we are and what we do. I think it really exposed the fundamental weakness of medicine, where all these, I hope no one's an administrator, sorry, but a lot of lay mass administrators that have gone undercover for a month doing Zoom meetings and haven't shown their scared asses into the hospital while we've been there blazing away and working. Now are coming back and patting themselves on the back, but the reality is the doctors and the nurses really run the hospitals. We ran these things with no gear. We saved a lot of lives, and I'm glad that we have regained the public's confidence and trust and standing. And I hope now as things come back to normal, we don't forget what a special place we have in our society's standing, and that we don't blow it, because I think a lot of my colleagues really got away from the concept of actually changing lives and making a difference for the greater good of our communities, our country. And I think this is it's a horrible tragedy, but really an amazing opportunity. I'm very excited to see what happens when we reemerge.
Thanks so much, Dan. And I think if I didn't leave anyone out, I'm gonna leave it for Alan and Anne Marie to add their comments. And Alan, just so you know, you are one of our panelists, even if you may not self-describe it that way. So,
Cameras.
I'll let you decide which of the two of you wants to make a comment first.
Well, there's lots of great comments. I appreciate everybody. I will say the pandemic really has brought out, I think, the true colors in many people, and most of it has been just fantastic. There's been incredible altruistic and heroism in a lot of the people we work with. It also has brought out a few people who maybe didn't go into medicine the same way, that with the same motivations that Catherine and this group did. So it's some of the other people have commented, it's been a good experience to kind of sort people out.
Yeah, and I hate to add anything else because what everyone said was just brilliant, but I would say that as a resilience researcher, I think the question about physician resilience has been answered in this pandemic, right? That physicians and other healthcare workers clearly have strong inherent resilience, because how else would you be doing what you're doing in the midst of this event? So I can stop my line of research on that and just call that part done. So.
We did have a record month in Illinois, $40 million of marijuana through the, so they were successful in generating some revenue and keeping people calm or paranoid.
Was that physician use?
I don't know. I believe there were.
Well, excellent. I just want to express my gratitude to everyone that here on the panel, everyone who's here in attendance. We will share the recording to our audience so that those that missed it can benefit. In sort of closing announcements, I just wanted to highlight that we thought we would start transitioning into a mode of doing this every couple weeks. Once weekly is getting a little busy for Paul and me, particularly with many of the other things that we have going on. And we hope that all those that we've touched in the last several weeks will stay connected with the other activities or just broaden our community. But we will do another focus group on Tuesday, 5 p.m. Pacific. This Sunday, we're doing another Yoga to the Surgeons, Sunday, May 10th at 5 p.m. Pacific. And we've been holding information sessions on our physician coach training, usually Mondays and Thursdays at 2 p.m. Pacific. So we have one this Thursday and one next Monday. And if you've been on previous calls, we were going to try and do coach training this week and next, and realized we were overcommitting. And so we've adjusted, and we're going to launch our online physician coach training, which is incredibly versatile to the surgeon life. Anyone furloughed can be interested. Anyone who's super busy, they can jump in because the program's incredibly flexible. And we start with a 4.5 hour segment. So it's 4.5 hours